Welcome back, clinicians. You're tuning in to the second explainer in our Australian Dizziness Clinic series. Let's dive right in, shall we? Today, we're taking the vestibular schwannoma clinical syndrome and translating it into a highly structured, evidence-based diagnostic protocol. We're targeting vestibular physicians, neuro-otologists, advanced ENT trainees, and senior vestibular physiotherapists, so you know we're going to get highly specific.
Here's our clinical roadmap for today. 1. The diagnostic challenge. 2. Clinical presentation patterns. 3. Audiological assessment triggers. 4. The gold standard MRI. 5. Vestibular function testing. And finally, 6. The diagnostic pathway. We'll be moving straight down the funnel from initial suspicion to definitive diagnosis.
Okay, Section 1, the diagnostic challenge. We've got to start by addressing a massive gap in contemporary neuro-otology practice. Just look at this staggering number. 3 to 7 years. That's the typical prolonged pre-diagnostic interval for vestibular schwannoma. Patients are literally walking around with progressive unilateral audiovestibular symptoms for years before a scan is even ordered. This is a blind spot we absolutely must aggressively shorten in our clinics.
But while most cases creep up slowly, we can't ignore the acute presentations. If you see a sudden unilateral sensory neural hearing loss, keep in mind that 1 to 2% of those are actually a vestibular schwannoma. In fact, sudden hearing loss is the presenting event in up to 20% of cases. Please don't let that fool you into diagnosing idiopathic sudden hearing loss without a scan. The rule is simple: gadolinium MRI first, questions later.
Moving on to Section 2, clinical presentation patterns. It's actually kind of amazing how predictably these symptoms stack up when you look at the anatomy. This 3D graphic hits the nail on the head. You can clearly see the tumor arising right from the vestibular nerve. As it expands inside that tight, bony internal auditory canal, it compresses all those adjacent structures. This is exactly what drives our classic triad: unilateral hearing loss, tinnitus, and disequilibrium.
And here's the big one. Asymmetric sensory neural hearing loss is the undisputed cardinal symptom, showing up in 95% of patients at diagnosis. 95%. If you see asymmetric SNHL, vestibular schwannoma has to be at the absolute top of your differential.
But what does the rest of the clinical picture look like? Well, look for unilateral tinnitus. That's present in 70% of cases, often high-pitched and persistent. Imbalance hits about 50 to 70% of patients. Interestingly, though, true rotatory vertigo is pretty uncommon, seen in fewer than 20% of cases. Also, watch out for facial numbness or weakness. If you see that, you're likely dealing with a larger tumor crowding the cerebellopontine angle.
Let's pause to compare these two profiles because, honestly, it's a huge point of confusion. Why chronic unsteadiness over true vertigo? It all comes down to the slow, insidious growth of the tumor. That gradual vestibular deafferentation gives the brain time to actually kick in partial central compensation. It perfectly explains why your patients complain of feeling just a bit off balance rather than experiencing acute room-spinning vertigo.
Right, let's jump to Section 3, Audiological Assessment Triggers. This is where standard audiology forces a strict pivot in our clinical pathway.
Pure tone audiometry with speech discrimination is your bread and butter here. You're looking for an asymmetric SNHL pattern combined with rollover on speech discrimination testing, meaning an ROI greater than 0.35. That combination right there, that's your cardinal red flag, mandating immediate further investigation.
Which brings us to Section 4, the gold standard. MRI, the absolute non-negotiable anchor of the entire diagnostic protocol. This scan perfectly captures what we're looking for. Right there in the axial view, you can clearly spot that classic ice cream cone appearance, the larger cerebellopontine angle mass with that narrow internal auditory canal component. Make absolutely no mistake, gadolinium-enhanced MRI is the gold standard. It gives you approximately 100% sensitivity for vestibular schwannomas larger than 3 millimeters. It is quite literally the only test that definitively confirms or excludes the tumor.
Section 5, Vestibular Function Testing. Okay, so if we've already confirmed the tumor with an MRI, why do we need functional testing? Let's take a look.
This table is incredibly high yield. Imaging gives us the anatomy, right? But functional testing, vHIT, calorics, cVEMP, ABR, gives us the physiology. These tests quantify the precise degree of nerve dysfunction. That is absolutely vital information for your staging and for figuring out your post-treatment rehab strategy.
When you map out the median sensitivities here, you see exactly why vHIT is such a game changer. Hitting 90%, it shows ipsilateral gain reduction with those telltale corrective saccades. It's a fantastic, rapid way to confirm deafferentation right in the clinic.
Let's pull the whole shebang together in Section 6, the diagnostic pathway.
This flowchart is brilliant because it basically maps out your clinical reasoning on a single page. You start with clinical suspicion, branch right into audiometry, enforce that mandatory MRI, and finally round it out with your vestibular function battery. It's your ideal clinical funnel. To wrap this up, let's hit our key takeaways. Number 1, asymmetric SNHL mandates a gadolinium MRI. Period. Number 2, the MRI is the only test that confirms or excludes VS. But don't skip the functional tests. vHIT and calorics characterize the degree of dysfunction, and they are vital for your staging and rehab planning.
This sets us up perfectly. In Explainer 3, Grading Classification and Active Surveillance, we're going to work through the KOOS grading system and the evidence-based MRI surveillance protocol.
Thanks so much for tuning in to this Explainer series. For more clinical deep dives on dizziness, vertigo, and imbalance, and to grab some great clinician materials, head over to AustralianDizzinessClinics.com. Don't forget to subscribe and rate the series. I'll leave you with this. Next time someone walks in with just a bit of asymmetric hearing loss, are you going to wait and see, or are you going to scan first and ask questions later? Catch you next time.